Greek medical theory understood health as a balance of humours, and anything that disrupted that balance, including skin eruptions or parasitic infestations, was seen as internal corruption demanding evacuation. Apathetic lesions, ulcers and rashes that resisted treatment were taken as signs of deeply rooted disorder. This justified extreme interventions over gentler ones. In mining settlements across Thrace, Cyprus, and the Anatolian interior, local healers began administering intense mineral drugs drawn directly from the trade around them. Powered by access to cinnabar, galena, and native mercury, they crushed and mixed these substances into ointments or drinks. The substances often burned, scarred, or induced vomiting, but withdrawal brought quick relapse. Because success was judged by visible effect, blistering, agony, discharge, patients and healers alike began equating suffering with progress. But some didn't recover. When patients died or worsened, practitioners blamed improper balance or insufficient vigor in the treatment, not the metal itself. The result? Escalating doses, reinforcements, and a pattern that future healers would inherit without question. Roman medical authorities gathered thousands of substances into systematic texts, but their classifications favored observable reactions over measured safety. Substances like quicksilver and orpiment appeared in remedies because they produced rapid, visible responses, blistering, discharge, or parasite death. In such a framework, poisons could earn legitimacy simply by producing proof of action. Without standardized units or repeatable dosing, a preparation that helped one patient might permanently injure the next. A mercury ointment that eased ulcers in a soldier could blind a merchant with scalp sores. Rather than question the compound, physicians interpreted these failures as signs that the patient required a stronger, costlier regimen. This reframed escalation as responsibility. Apothecaries began preparing even more aggressive formulations, layering toxic metals with plant volatiles or alcohol extracts meant to drive the agent deeper. Success became harder to prove and failure easier to hide. Once physicians had accepted poison as technique, the idea of restraint became harder to defend. By the 9th century, Islamic and Latin physicians absorbed alchemical techniques into medical texts, detailing how to sublimate mercury into fine white calomel or distill arsenic into crystalline powders. These techniques, adapted from philosophical treatises, passed through apothecaries as legitimate therapy. They promised purification, cleansing the body through corrosion, bleeding, or chemical shedding. But the promised cures rarely lasted. Chronic ulcers reopened, skin lesions returned, and parasites re-emerged weeks after apparent success. Faced with relapses, physicians responded not by withdrawing treatment, but by repeating it, restoring the same corrosive regimen, this time with greater intensity or frequency. Side effects, fevers, fainting, tremors, were reframed as signs of internal resistance. Over time, patients underwent cycles of retreat and return, their bodies weakening with each exposure, but conditioned to expect that suffering signaled improvement. Few physicians recorded long-term outcomes. Instead, the persistence of illness justified sustained intervention. The poisons became routines, and once healing was defined in terms of reaction, stopping became harder than continuing. When the outbreak of the French disease swept through Europe in the 1490s, treatments that had managed skin rot and ulcerous eruptions for centuries collapsed into failure. Surgeons documented pustules that spread despite lancing, and court physicians recorded flesh that blackened without response. Familiar tools, bleeding knives, herbal decoctions, vinegar compresses, proved useless. Facing a sickness that disfigured the groin and face, authorities turned to mercury, not because it cured, but because it showed action. In ointments rubbed into lymph nodes, in drinks laced with cinnabar, or in steam baths that suffocated patients in mercury fumes, the treatments inflamed sores, triggered sweats, and loosened teeth. Still, disease returned. Surgeons concluded the failure lay in insufficient intensity. They extended the mercury courses, demanded closer shaves for better absorption, and dosed earlier in the outbreak. But as reactions worsened, drooling, hallucinations, fatal convulsions, they blamed late presentation or moral impurity, not the cure itself. From that point forward, retreat no longer looked like prudence. It looked like negligence. Inside mercury sweat houses, patients were stripped, greased, then shut in for hours as furnace heat drove salves into open pores. Each session left them drenched, disoriented, and reeking of metal. Drooling and tooth loss, now unmistakable signs of mercurial exposure, were seen as proof the poison had found its mark and driven the illness outward. When conditions worsened, treatments were not paused, they were intensified. Inunctions were reapplied daily, sometimes without washing off the last layer. Teeth loosened until they fell out, mouth ulcers split into raw craters. Yet physicians read these breakdowns as therapeutic, not injurious. If the patient declined, the mercury was increased, not withdrawn. This logic left no room for reversal. By accepting suffering as progress, doctors trapped themselves in a cycle of recognition that only red action, never harm. Mistaking corrosion for cure, they made prolonged poisoning a protocol rather than a risk. And once the body had been reshaped by mercury, retreat no longer meant survival. It meant abandoning hope. By the turn of the 17th century, frustrated patients and ambitious physicians began turning to arsenic not as a last resort, but as a cleaner, newer option. Unlike mercury, it could be disguised in sugared tonics, wine-based elixirs, or refined powders with no oily residue or immediate stench. Arsenic's appeal was its subtlety. Almanacs and dispensaries praised it in small doses as a reviver of strength and clearer of the skin. Applied in ointments or swallowed in cordials, it promised vigour without drool, rosy cheeks without sweat houses. But its effects were harder to track. When faintness, stomach pain, or skin peeling followed, many blamed climate, appetite, or age. The more invisible the damage, the easier it was to attribute failure to anything but the drug. Physicians began layering arsenic into daily remedies, digestive bitters, menstrual tonics, even cosmetics, on the theory that weaker concentrations held no threat. But low visibility opened a new danger. Now, poisoning could progress without ever resembling a cure gone wrong. Physicians, seeking to salvage arsenic's promise while minimizing its chaos, began supporting more consistent formulations by the late 1700s. Apothecaries turned to measured drops, mineral suspensions, and branded mixtures touted as modern remedies. One leading example was Thomas Fowler's solution, arsenic trioxide dissolved in potassium bicarbonate, bottled, labelled, and sold as a safe general tonic. Fowler's solution entered recommendation lists for conditions as varied as psoriasis, epilepsy, and intermittent fevers. It looked controlled, measurable, but toxicity still followed. Nausea, weakness, and collapse were now harder to trace. They appeared weeks or months later without dramatic signs of poisoning. Deaths continued, but with symptoms that mirrored known diseases or age-related decline. This ambiguity changed how risk was interpreted. Because dosing appeared regulated and the poison polished, physicians blamed outcomes on patient fragility, not the preparation. Arsenic's hazards blended perfectly with other diagnoses. The cleaner it looked, the easier it spread. And with devastation now decoupled from spectacle, it became harder, not easier, to recognize poisoning at all. In hospitals across Britain, France, and the American Northeast, Fowler's solution became a prescribed constant, measured in drops, dosed in intervals, praised in journals. For lung conditions, it was added to syrups. For skin disease, rubbed through salves. But when patients returned with tremors, fatigue, or darkened fingernails, practitioners didn't suspect accumulation. They blamed the disorder's return. Rather than withdraw the arsenic, physicians layered it with new compounds, antimonials, strychnine, even low-dose mercury, arguing that alternating toxic agents could shock the illness into retreat. Complex prescription schedules emerged. 3 days of Fowler's, then a purge, then an opiate, then back again. These rotations masked symptoms long enough to suggest progress without arresting the decline. When patients deteriorated, doctors narrowed blame to timing or temperament, not the agents themselves. The very flexibility of rotating poisons insulated them from suspicion, as each failure could be blamed on another compound or the body's resistance. With causes diffused and harm delayed, the cycle tightened. No single poison was guilty because every poison was necessary. By the 1840s, arsenic-based medicines had spread from elite dispensaries to household cabinets, often without labels, warnings, or fixed formulations. Arsenic powders were sold by apothecaries for complexion, vigor, or monthly regulation, while physicians prescribed Fowler's solution for nerves or lingering flux. But without uniform dosing, any bottle could drift from treatment to weapon. The case of Marie Lafarge, accused of murdering her husband in 1840 using arsenic she claimed was medicinal, exposed how indistinct the line had become. Chemists debated test results in court. Physicians disagreed on toxicity thresholds. The case fractured public confidence, not just in Lafarge's guilt or innocence, but in the authority of doctors over poisons they could no longer control. With suspicion growing around remedies that could also kill, some physicians began turning to lab-derived compounds promising precision. German pharmacies produced cleaner alkaloids. English firms promoted chemically pure tonics. These new drugs offered measurable doses, but they were unproven, unregulated, and sometimes repurposed from industrial chemistry. The search for control had simply moved the risk forward. By the 1880s, hospitals and private clinics began promoting chemical specifics with names, measurements, and advertised effects. Chloroform, phenol, and salicylic acid entered as antiseptics, while new alkaloid derivatives like cocaine and digitaline were hailed as targeted, neither purgative nor corrosive. These were championed as signs of progress, precision where mercury and arsenic had been blunt force. But while newer drugs gained prestige, mercury and arsenic never disappeared. In wards treating recurring skin infections or syphilis, old compounds returned quietly in compounded salves or legacy prescriptions. Even in cutting-edge city hospitals, children with scabies were rubbed with calomel, and arsenic was prescribed for facial neuralgia, its past ignored if results appeared. Pharmacists, still unregulated in much of Europe and North America, stocked both old and new medicines side by side, often mixing them to satisfy doctors' instructions or patients' demands. Without central oversight, dangerous hybrids emerged, arsenic in antiseptic lotions, mercury in obstetric powders. While medicine promised modern control, toxic traditions remained just beneath the surface.